Hi there, my name is Pauli. I'm a professor of surgery at Penn State Hershey Medical Center, and I'll be talking about parastomal hernia repair techniques. It's a pleasure to be here speaking today. These are my disclosures, which will not have any bearing on the talk. I'd like to review some technical considerations and some outcome data for a variety of parastomal hernia repairs, and to describe essentially an algorithm of parastomal hernia repair techniques. We'll ultimately also talk about some novel repair techniques for parastomal hernias. Whenever I talk about parastomals, I begin with this paraphrase from Shakespeare. Some people are born great, some achieve greatness, and some have it thrust upon them. Your fate awaits you, accept it in body and spirit. For reasons that are unclear to me, I have had parastomal hernias thrust upon me for the better part of a decade now, and I have still not yet learned to accept it in body and spirit. These are exceptionally challenging problems even in 2020. We've heard from earlier in the session about how common parastomal hernias are. They occur in up to 50% of stomas. We know that they are technically difficult to repair, having a higher rate of recurrence, a higher rate of surgical site occurrences, most notably surgical site infections. Here we see a well-repaired parastomal hernia with a piece of EPTFE that only a few years later is a recurrent hernia due to mesh dislodgement from the abdominal wall laterally. We know that you have added morbidity of stoma-related complications. Here we see a patient who had a stitch put in the stoma and a subcutaneous fistula has developed as a consequence of the parastomal repair. We also know that midline hernias occur concomitant with these at a very high rate, which further complicates your ability to manage the parastomal hernia because you are no longer repairing it in isolation. Why do we fix these? Well, we fix them for the same reasons we fix a lot of hernias: incarceration, types of bowel obstructions. I'll note that obstructions can occur both at the level of the stoma itself and at bowel proximal to the stoma. Here we see a CT scan of a patient who actually had a gastric outlet obstruction as a consequence of a parastomal hernia. Pain and discomfort, sure, just like other hernias, but we also have to add in poorly fitting appliances. We know that some patients have significant issues with ostomy appliance fit that can lead to skin irritation and infections, and those problems may coexist with the presence of the parastomal hernia itself. This patient's primary complaint to me was not only ostomy appliance fit, but the cosmesis of this. He was being stopped at grocery stores and accused of shoplifting due to the large parastomal hernia that he had traversing his right-sided semilunar line. We've already seen a wide array of slides of parastomal hernias, and when I give talks about parastomal repairs, I talk about all of the options that are out there, and I usually break it down into primary suture repairs and then mesh-based repairs. The suture repairs can either be leaving the stoma in situ or relocating it to a new spot. Leaving the stoma in situ can actually be accomplished by both taking down the mucocutaneous junction and doing a repair, or working in an incision that is parallel to the stoma in some fashion and leaving the mucocutaneous junction intact. A mesh-based repair can be done both open and minimally invasively. Most MIS repairs leave the stoma in situ and then configure the mesh around the stoma, usually with a slit or a keyhole type configuration, but more commonly in an era of modern laparoscopy with a sugar baker type repair where there is no slit made in the mesh. And we'll talk about that in a few minutes. Open repairs come in a wide variety of shapes and sizes. Again, the stoma can be left in situ with mesh being slit around it, or also keyholed. We also know that mesh can be a cruciate if the stoma is relocated. So, this is kind of a broad swath overview of what the options are in terms of general configurations for the repair. I think the important part of this slide is really that the hernia surgeon, being faced with the clinical scenario, is able to take a look at all of these options and bring to bear the best option for the patient at the time. None of these options are necessarily ideal in every scenario, and obviously having all of these sort of arrows in your quiver is very helpful. We know that suture repairs have a very high recurrence rate. If you have a recurrent hernia, the chance of getting it back after a suture-based repair is basically 100%, which is roughly 9-fold higher than a mesh-based repair. But it has a lot of advantages. It is technically very simple to do. It avoids relocation. It avoids the use of mesh, which we know can get infected, and in general has a low morbidity because it can be done via one of a variety of local incisions. As I said, it does have a high recurrence rate. Similarly, relocating the stoma to a new spot also has a high recurrence rate. That's because you have a new stoma site, which has a 25% chance roughly of getting a hernia, and an old stoma site, which again, if it's a suture-based repair, has a roughly 50% chance of getting a hernia. This generally is done via a laparotomy, and so you have several wounds to deal with: a midline laparotomy incision, a new ostomy and mucocutaneous junction to manage, and an old contaminated wound. So again, a good option in some circumstances, provided that you are willing to accept a high recurrence rate. There are some downsides, though, and the downsides of this include the fact that as you start moving the stoma to new locations, you start burning bridges for subsequent repairs, and that needs to be considered. This is a great study from colorectal diseases in 2004. It looked at 51 consecutive parastomal hernia repairs. It broke down into roughly a third primary repair, a third a local repair, and roughly 1/3 where the stoma was relocated and the old stoma site was repaired with mesh. And if you look at the outcomes, they reported a 38% recurrence rate overall, with the highest being in the primary repair group. The next, a local repair with mesh at 39% recurrence. When the stoma was relocated and things were repaired with mesh, you had a 24% recurrence rate overall. And again, not well reported, but most of the recurrences are coming through the new stoma site. So it seems that if you're going to do this, relocating the stoma and repairing the old site with mesh may be the best viable option of those three categories. Let's talk a little bit about mesh now and think about our options for mesh-based repairs. I mentioned the word keyhole before. A keyhole repair is one where we make a slit in the mesh and then wrap the mesh around the ostomy. This can be done in any of the abdominal planes for hernia repair. That includes an intra-abdominal or an underlay repair. It can be done in the subcutaneous space as an onlay repair, and it can be done in the retromuscular space as a sublay repair. The key factors here are that the mucocutaneous junction is generally left in situ. The mesh slit should be closed with permanent suture because you have created a defect in it. A sugar baker repair is traditionally thought of as an underlay or an intra-abdominal operation where the bowel is swung around the lateral edge of the mesh. This results in no cuts or slits in the mesh that can open up or contract over the course of time, resulting in a recurrent hernia. As I said, this is traditionally an intra-abdominal operation. I'm going to show you some sublay options for doing this operation at the end of the talk. A cruciate basically involves making a cut in the mesh. Typically, we think of this as a repair where the mucocutaneous junction has been taken down and the stoma is being reformed through the mesh. So again, that mesh can be placed in an intra-abdominal position, in a subcutaneous or an onlay position, or in a retromuscular position. Those are all possible. Just one brief slide to say that there is no data supporting the use of a biologic mesh over a synthetic mesh in parastomal hernia repairs. I think if you're going to use a permanent, you need to use a larger pore, generally reduced weight polypropylene mesh, and there is data to show that this is safe, effective, and certainly less expensive. But you must be comfortable with the clinical situation. Obviously, Crohn's patients and those with IBD are a very different population. And I think a dedicated discussion with the patient about what mesh you're planning to use in them is obviously mandatory. So when I meet somebody and I'm thinking about all of these options for repair, how do I address them? Well, my repair algorithm looks something like this. If it's a small parastomal hernia with really minimal midline component, I think this is a great option for a laparoscopic or a robotic sugar baker operation done intraperitoneal. Here we see a very small parastomal hernia. This is one that is easily reducible. The bowel has enough ability to mobilize it, to move it lateral. Here we see a piece of EPTFE being utilized for this repair. But once you get to a larger parastomal hernia, or one that has a moderate or large midline component, I think a variety of other options become necessary. For example, this patient here has a hernia that is traversing the semilunar line. We can see the right-sided rectus abdominis here. We can see intact external oblique. We can see a transversus abdominis and an internal oblique that are partly disrupted, and a stoma that's been formed essentially through the semilunar line. These patients require a more complex consideration. This patient here has a large midline hernia with minimal to no parastomal component. But again, in order to repair this midline hernia, if we're doing a cruciate or a keyhole of the mesh, we're cutting the mesh within several centimeters of the repair of this large midline hernia and potentially compromising that repair. And so understanding options becomes critical here. If I don't want to relocate the stoma, we have some options that include keyhole, mesh incisions, or what we'll describe at the end as a Pauli parastomal hernia repair technique. If we're going to do a TAR-based repair, that generally starts with taking down the stoma and we're going to relocate it to a new spot. We know that if you do this, you're going to have a hole in the posterior layer of the deconstruction where you did the TAR, but essentially a transversus abdominis release can be performed working around these defects. That old defect site in the posterior layer is closed. The midline posterior sheath is closed in a standard fashion for this operation, and a new stoma site is created in the posterior layer to deliver the bowel. We then put mesh into the field and create a cruciate to deliver the bowel through the mesh. We then create a defect in the skin, subcutaneous tissues, and rectus abdominis muscle. And here's a cross-sectional view of what that repair looks like. You can see the midline and the old stoma site are widely reinforced, and the new stoma site is pulled through the mesh, so we essentially have primary mesh reinforcement of the bowel from the very get-go of this operation. Here we see a cross-section of that. Again, the old stoma site is widely covered with mesh. I think the biggest downside is that by putting a cruciate here and cutting it, not only have we resulted in an area of the mesh that may contract over the course of time and open up, resulting in a new parastomal hernia, but because many of these cruciate defects occur within several centimeters of the midline, if there was a midline hernia here, we're also compromising the midline repair. I think the second thing to consider is that lining up the posterior sheath, lining up the mesh, and lining up the anterior layers, which are all freely floating and independent from one another, can be very challenging. To address that issue, Yuri Nowitzki described a storm operation, which is designed to really minimize the angulation of the bowel as you come through all of those layers. This is done by essentially utilizing the anvil of an EEA stapler and utilizing that to come through the mesh itself and through the anterior layers of the abdominal wall. So the staple and the anvil are coupled, and when the staple is fired, you've essentially joined several layers of the abdominal wall together. This prevents friction and motion and potentially reduces the risk for angulation as the bowel goes through the abdominal wall. The bowel can then be delivered in a standard fashion and the mucocutaneous junction reformed. When we think about parastomal hernia repairs utilizing a TAR, we know that there's an acceptable risk of recurrence. The stoma is relocated but also reinforced from the very beginning, and you do have wide sublay mesh covering the defects, albeit with the notable exception of the cut that is made in the mesh itself. This definitely is a great option for a repair that needs to take into consideration large midline components, and as I said, there's good literature supporting the use of polypropylene mesh. In the first publication of this from Drs. Rosen and Nowitzki, 46 patients were repaired, 70% of which had large midline hernias associated with it. And at 13 months, they reported an 11% recurrence rate with a variety of surgical site occurrences that you might expect. And I'll point out that these are stoma-related complications like mucocutaneous junction separation and ischemia. But notably, no specific mesh complications or long-term fistula. As I said earlier, though, this operation has some difficulties. Not only is it complex and you have to know how to do a TAR, but you've got an old stomacite and a new stomacite to manage, plus a midline wound which can get infected. You are transecting and you need good bowel mobilization to transpose it to the contralateral side. And as I've said several times now, the mesh is cut, and that is generally where most of these recurrent hernias are happening. And so that's where a Pauli parastomal hernia repair comes into play. This is really simply a tar combined with a sugar baker. Some people call it a retromuscular sugar baker. It's a very accurate description. This operation came about when I was doing a tar one day, trying to leave the stoma in situ, and I realized that I could simply lateralize the stoma in the retromuscular pocket. That allows the mesh to not be cut, but also to keep the stoma in situ. I'll also say that this is extremely challenging to configure correctly. Again, this is a retromuscular dissection that's taken place, leaving the stoma in situ, and then we perform a tar, leaving the stoma in place. This is a view of the completed transversus abdominis release with all of the lateral dissection done. At this point in the operation, we do the thing we tell you not to do, which is to intentionally create a hole in the posterior layer. So we cut the bowel along the direction the mesentery is running to allow it to be lateralized, and then we close that lateralization from lateral to medial to essentially retroperitonealize a large portion of the bowel, in this particular case a descending end colostomy. So that's the closure. The right and left-hand sides of the sublay space are closed in a standard fashion, and then this entire sublay space is filled with a large piece of mesh, allowing the bowel to essentially be lateralized and the mesh to be in a sugar baker configuration. Here's a cross-sectional view of what that looks like. You can see here the bowel moving lateral around the mesh before it comes up, so both the stomacite and the midline are widely covered with no cuts in the mesh. Here's an AP view of what that looks like. In this particular older drawing, we're showing you lots of transfascial sutures. I have really stopped using transfascial sutures for all of these repairs presently. I'll also make a brief note that this operation can be performed robotically as well, either as a unilateral dock if you're really only repairing the parastomal component. So this can be a unilateral retromuscular parastomal hernia repair. If you have a large midline component or need wider overlap of the defect, you can do a double dock technique with 3 mirror image ports on each side. Here's a robotic view of what that deconstruction looks like. You can see the posterior sheath has been taken down around the parastomal hernia, leaving the ostomy in situ here. Similarly, the posterior sheath is cut to lateralize the bowel and then sewn from lateral to medial. Again, a very challenging operation to perform, but in a minimally invasive approach, obviously reducing the midline wound component has many, many advantages. This repair looks very challenging to interpret postoperatively as well. Here we see the pre-op image of a patient who had a Pauli parastomal hernia repair. Here's the postoperative imaging. We can see this descending colostomy entering the retromuscular pocket here. This is the posterior sheath and the mesh. What I like about this image, though, is that you can see the gentle bend that this bowel takes as it enters. We really want to avoid kinking and angulation at this level, as that will not only put tension on the bowel, potentially resulting in an obstruction here, but also allows the bowel and the mesh to have an area where they interact at a tight angle, potentially leading to fistula formation. The largest series to date of this is from Mike Rosen and his team at the Cleveland Clinic. They performed this operation on 38 patients. Again, the majority of these patients, at 92%, had a large simultaneous midline hernia, and as you can see, a large use of permanent synthetic mesh here. They again reported an 11% recurrence rate at 13 months, but they had 3 issues related to mesh erosion. 2 of these occurred within the first 2 weeks, and I think that this being very early in everybody's experience with this technique, I think an attempt was being made to lateralize the bowel and place lots of transfascial sutures, which probably resulted in some angulation and some ischemia as a consequence of very early mesh erosion. One of these was an ischemic stoma occurring 4 months out. Again, this patient had some early complications and was also a patient with fistulizing Crohn's. So again, caveat emptor here, this operation has good success in expert hands, but it's extremely challenging. I'll also point out some novel mechanisms of recurrence. This is that same patient that I showed you earlier of mine who presented back with actually a mesh fracture medial to the lateralized bowel. And so as we go back and look here, what we can actually see is a section where the stoma is still lateralized and coming up through. So the sugar baker component is still present, but what we're actually seeing is a central mesh fracture occurring medial with some small bowel coming up through. My lab resident, David Morell, is going to present this this year at AHS in the fall. I'll conclude by saying there's really no ideal way to repair parastomal hernias, and when you add the presence of a midline hernia, that simply serves to further complicate the repair algorithm. As a hernia surgeon, I think you need a variety of approaches to manage this very complex clinical situation, and you need to be humble because these repairs can be quite challenging. Happy to answer any questions during the question and answer session. If you have anything else, please feel free to email me. Thank you.